it's going to be 150 to 200 billion for these drugs by 2035. So that's a huge market.
So which company should I be investing in? Novo or Eli or both?
Both, right? Eli's going to take off in the short term with a new drug. People are going to be like, oh, Wegovy's not available. Let's switch everyone to Zepbound or Mounjaro. But just if these two companies are the only ones that have market share for, X amount of years, stock price is going to go through the roof. Welcome back. Another episode of the Orange Pill Club.
I know,
Happy
it's pretty
Friday.
exciting. Yeah, happy Friday. It's finally we have a name for this podcast.
I
So I
know.
think we've been trying to figure out a name for this podcast and we've been struggling for so long. But there's definitely a lot of different things that are happening right now in the pharmaceutical industry. And I actually wanted to sort of like tell everyone like this is actually like breaking news, like what's going on. Let me pull this article up. So recently, Novo Nordisk, they're a manufacturer of this insulin called Levemir. They've announced that they're going to be pulling it off the market following the end of this year. So I think this is pretty crazy because Levemir is used by so many people. But what's also interesting is that Novo Nordisk also owns Tresiba, which is another long-acting insulin. So what does this sort of mean? And what I found interesting in this article, it says, Novo made the call on Levemir after careful consideration, citing global manufacturing issues, decreasing patient coverage, and the availability of other options for patients to choose from, it said in its discontinuation notice. Earlier this year, Novo opted to slash Levemir's price point by 65%, a move which was to go in effect come January 1st. Obviously, that's not going to happen anymore. The company also sliced the cost of its Novolog insulin by 75% and matched Levemir's 65% for its Novolin. So yeah, it's pretty interesting. In terms of insulin, I mean, it's used to treat diabetes, type 1 and type 2. I think it's kind of dangerous to see less options on the table now. And I see that the manufacturer is saying, we have global manufacturing issues, decreasing patient coverage. But I wonder how a lot of pharmaceutical companies are reacting after the Inflation Reduction Act. You had a lot of companies that decided to reduce their insulin price point. But it seems to me that as a result of the Inflation Reduction Act, it's possible that Novo Nordisk is just saying, look, we're not making enough money for this drug because we have to take into consideration this act that happened. But I'm curious, Amr, I wanted to get your thoughts here. I mean, do you think it's kind of dangerous that, we're pulling Levemir off the shelf? Like, what are your thoughts?
I mean, personally, I haven't seen much dispensing of Levemir versus the other options. So I don't necessarily know if it's more coverage thing because it's one of the most covered insulins on the market. It's one of the oldest insulins on the market, like long acting. So I feel like a lot of that's just bullshit. But if I'm being completely honest, they got the force to reduce their prices. And then they're like, all right, well, we're not going to make money on this anymore. And we have other drugs coming down the pipeline. So we're just going to discontinue it. I think that's the realistic narrative. If you ask me, from a business standpoint, that's exactly what it is. I mean, it's not sugar coated in any way. They literally cut their prices. That's going to take effect in 3 months. And they're like, all right, well, there's other options now, and this isn't covered as much, and we can't make it that much anymore. So let's just take it off the market.
Yeah, what's interesting is, Novo also owns Tresiba, which is also another long-acting insulin. I imagine that the rebate structure is much different from that of Levemir. So I imagine it's probably much more profitable for Novo to push Tresiba over Levemir.
Let's see. What other products does Nova have?
They have so many products, and this is just for their insulin
Well, yeah, I
portfolio.
mean, in terms of insulin, they got Fiasp, which is short acting. They got Levemir, which is going to come down, Novolin, Tresiba, and then obviously the semaglutides or the Ozempics and those, right?
Yeah, but I
Ozempic
mean,
and
Ozempic isn't really an insulin. I mean, that's a more of a GLP-1, but
right. but I
Yeah,
think more people are shifting towards those. I mean, there's always going to be a need for insulin,
of
but
course.
with these newer agents that are working far better, I think a lot of these big companies are just kind of seeing what they can, how they can trim the fat on their balance sheets ultimately.
Yeah, that's a big component of it. I do wonder who's going to be picking up this patent. I'm sure there will be some patent trolls that are out there and says, "Hey, look, this is a great patent to buy," and maybe people aren't going to produce it right now, but maybe in the future, if something were to happen to Tresiba or the other long-acting insulins. But yeah, I've always found it really fascinating how the world of pharmaceuticals just plays out in terms of the economics.
It's always, I mean, you got to remember, anytime like a medication goes generic, that same company will change something on the molecule on the compound, make it a better drug, and then put out a new branded drug, and they get that 7 to 10 year runway, and it's just that cycle. That's how it is. So it's not like it's kind of hidden in plain sight. It's like, all right, this went generic. It went from like Truvada, for example, it used to be like $2,000. Now a bottle of Truvada costs anywhere from like $6 if you get a great deal to 20 or $25 because it's generic. So Gilead said, all right, well, since Truvada is generic, we're going to come out with Descovy, which is slightly better, and slightly less impactful on your kidneys and better renal protection. That's what they market it as, and then you got Descovy, which is like $100 more than what brand Truvada used to be. And when that runs out, there's gonna be another one, and I think it's
Yeah.
just a cycle because at the end of the day, I mean, these are publicly traded companies; they gotta make money, right?
Yeah, it's like the Apple. It's like the Apple iPhone. They make these incremental improvements, and then they say, "Oh yeah, like we could just market this as a brand new drug that's much better than the older one." And I do wonder, like in their portfolio of all their drugs that they've researched, I'm sure they've already done the analysis of like, all right, let's launch this, then that.
Yeah,
Like, I'm sure they have some sort of tiered structure in terms of like how they release this drug and how they extrapolate as much value from the healthcare industry as much as possible.
right. No, there's always a timeline. It's like, all right, we're gonna release this one this year, and then 3 years later, we're gonna release this one. They always offset all their releases because they get the patents and they get the 7 to 10 year runway of being the only one on the market with the branded before it goes generic, and it's just how the pharma industry works.
Are you familiar with the history of insulin?
Not in depth, no.
So I do remember learning about this, but when insulin first came out, it was like derived from pigs, I believe.
Yeah, bovine.
Yeah,
Yeah,
or cows.
I
Pigs or
think
cows. Can't remember which one.
yeah.
But what was interesting is when people first administered insulin that was derived from one of these two animals, people would actually get like fat lumps in unequal places of their body. And I think that was like a big issue with like use of insulin in the very beginning. And then they just realized like the insulin needs to be synthesized in a different manner.
Hmm.
But I do remember, we've come so far with the way, diabetes is treated. And it's kind of like scary sometimes that insulin can be really expensive for a lot of, everyday people who don't have insurance coverage. But yeah, I mean, there's short acting, medium acting, even long acting. So, there's still a lot of insulin options, and Levemir is more of a long acting one where you typically give it, I think, like once or twice a day. Can't remember off the top of my head right now. But yeah, it's pretty interesting to see that this drug's getting pulled off the market.
It's yeah. I mean, that if you remember a while back, there was like this craze of branded generics, which was just another way of these companies making a drug generic, but it's still technically branded. So it's like still they can justify that high price, but because it's a branded drug, but it's really a generic, it's like an equivalent. So like that whole thing just seemed like an entire scam to me. Like when I first heard the term branded generic, I was like, what does that mean? Like, how do
Yeah,
you have a brand? You're just taking the med, it's generic now, and they're giving it a new brand name for a slightly lower cost.
branded generics was actually a really popular thing, I think, in like the early 2020s. I
Yeah.
still remember Valeant Pharmaceuticals was the one who was pushing this out. And then Valeant Pharmaceuticals got in huge trouble. I believe the CEO hired for, their chief of marketing, like some stripper. And the stripper would give lap dances to all these different doctors, like as a way of like enticing them to, place this product on their shelves.
Right.
But yeah, it was a big deal. I remember that a lot of these branded generics came out. Like it was just so redundant to the point of like, why do we need to have this as a drug? It didn't make any logical sense. I mean, you just can follow the money and say, like, every time a branded generic comes out on the market, they'll try to say, oh, it's easier on the stomach, or they'll come up with some sort of like incremental sort of improvement and say, hey, look, this needs to be covered by every insurance payer now.
Yeah, if you remember, like Advair went branded generic to Wixela, and then I want to say a year and a half later, like the actual generic came out, and then I have never dispensed a Wixela since.
A lot of people don't know this about the Advair inhaler, but the patent actually expired for almost like 7 to 8 years, and then there was no competitor on the market that could successfully replicate its design. Wixela was definitely another generic that came as an offshoot to Advair, but that came like 7, 8 years later after its patent expired. So
Right.
it's been pretty interesting. Yeah, I mean, I think that disc is what's really the most difficult part to sort of like recreate.
Right.
So I think that's where a lot of manufacturers had trouble sort of like saying, hey, look, how do we create another generic off this drug? It's just too expensive. But yeah, it was pretty interesting to see Advair, on the market for quite some time, well after its patent expiration.
Yeah, I think it's going to be a general trend also with these as newer meds come out. These companies are going to have to figure out a way to still generate that revenue, um, while having a product that everybody wants. It's like the movie industry now. If you realize, like they're just remaking the exact same movies over again. It's like
Oh, yeah.
there's no new idea, so it's like let's just recreate the old ones. It's like a very similar parallel in this too.
We covered the Inflation Reduction Act on one of our most recent podcasts. I think it was podcast number 2. And as a result of the Inflation Reduction Act, a lot of pharmaceutical companies can no longer increase their year-over-year drug pricing. It cannot exceed the CPI of what's reported by the federal government. But the thing is, the problem is that the CPI that's reported is much lower than the actual inflation rate. So I
Mm-hmm.
wonder if a lot of drug manufacturers are taking this into consideration, trying to rebrand some of their drugs, or if they're putting a new drug on the market, they're going to have to take into consideration this delta that could be clawed back by the government every time they increase the drug. So I do wonder, how much of the Inflation Reduction Act really plays a role here. But I was a pharmaceutical company, and I'm having my revenue reduced by Medicare. I have to now take this in consideration with all my current drugs in the portfolio and also new drugs that are coming out. But
You think it's
speaking of new,
gonna go?
oh, go ahead.
You think it's gonna be more of a trend of just these companies saying, "Hey, look, we can't increase our prices on the current drugs, so let's just put out more new drugs on the market that are pretty similar to the drugs we already have." I think that's gonna be the general trend.
I think what we're going to end up seeing is that when new drugs are approved and there's another indication for it, there's going to be a new branded name of that drug. And actually, that ties into our next segment here and probably
Yeah.
a bulk of our discussion today. It's actually Zepbound. So a lot of people don't know this, but Mounjaro and Ozempic, all these like different weight loss drugs have been the newest craze in America. I mean, this has been a new billion-dollar industry that was just realized overnight. A lot of physicians started realizing that as a use of GLP-1 medications, a lot of people were losing weight. You had Ozempic, then you had Mounjaro, but Mounjaro was never indicated for weight loss. It was pending FDA approval for such a long time.
Right.
As a couple of days ago, Mounjaro was actually approved for weight loss. But what the manufacturer did is they decided to brand this under Zepbound. So Zepbound is essentially the same as Mounjaro, but Zepbound has the FDA indication for weight loss. It does not have an indication for diabetes. Mounjaro is the only one that has the indication for diabetes, but it doesn't have an indication for weight loss. So I think what you're going to end up seeing here, again, this company is probably taking into consideration the result of the Inflation Reduction Act. Weight loss drugs aren't going to be typically covered under a Medicare plan, but diabetes drugs will.
Mm-hmm.
So if I'm going to take that in consideration, then I'm going to put Zepbound on the market. I know I'm not going to be clawed back for this drug because they don't cover weight loss. I'm going to price this a little bit lower than my competitor, but year over year, I'll probably still increase it by some magnitude amount. So we'll see what happens. But this is a new drug that came onto the market. Is Zepbound or Mounjaro better than that of Ozempic, Semaglutide? Really don't know, but we'll talk about that in the next couple of articles that we're going to pull up.
Yeah, I mean, this is a very So, they're literally following Novo's model of Ozempic and Wegovy. Each one has its own indication. Is Wegovy is not indicated for diabetes, right? They only have the weight loss indication, or was it both? I can't remember.
I think Wegovy is the one that has the weight loss indication. I don't know if it has the diabetes medication, but my understanding that it's the same drug, but just
It's the
branded
exact same thing,
differently.
yeah. It's
Yeah,
just
it's
one
just
comes in a
branded
small
differently.
box and one comes in a bigger box. One's one pen and the other one is four pens, I think. Mounjaro is the same way. Um, so yeah, they're following the same model, and they're both gonna obviously do really well. I think I just hope, because right now the biggest issue that I see is access, like the higher doses, which are the indicated doses that people should be on for the maximum results. None of those doses are available. So for
So in
Wegovy, right now, the lower doses that you need to get started on treatment are unavailable. Only the higher doses are available. And with Ozempic, the lower dose is available, but the higher ones are not. So anyone that's trying to manage their diabetes with Ozempic, they can't get the most optimal dose. And anyone who's trying to start their weight loss journey with like Wegovy, they can't get the lower doses to even get started. So it's just a
yeah,
deadlock of supply, really high demand and really low supply.
yeah, I think a big challenge with a lot of these subcutaneous injections is that in a pharmaceutical manufacturing company, they have to adhere to something we call aseptic requirements.
Mhm.
So, I mean, this liquid is essentially needs to be compounded in a sterile room, and they have to microtest it continuously, and they have to sample every batch to make sure that the liquid has the right concentration. There isn't any bacterial growth. There's a lot of controls here, but
Mhm.
as opposed to a pill, I mean, there's less controls to develop that. It's doesn't require a clean room or sterile room. So again, the production cost for I think these sterile injections is much more than that of developing it for a pill. And I think I was reading this article about Zepbound. It's been approved now this month, but how long is it going to take for this manufacturer, Eli Lilly, to start beginning production and we're able to see it on the commercial market?
They actually said it's right after Thanksgiving, so right in December. If you
It's
open
right
up
after
the
Thanksgiving.
yeah, which I thought was hilarious. Don't you think that's funny? I'm like, all right, everyone's gonna like have their holiday feast, and everyone's gonna get a little
Oh man.
chunkier, and then we're just gonna release this. Like they had it down to a T. The marketing and how when they're gonna release it is perfect. Holiday season, everyone's off. Everyone's probably gonna be in front of a TV. There's gonna be commercials for this, and they're gonna release it at the perfect time. Like
Yeah, that marketing is
whoever the
gonna be
marketing people
flawless.
are, they got it down.
That's gonna be flawless. Like, I don't know. Do you think it'd be better to do this after Thanksgiving, after Christmas, or after New Year's?
I think so. Here's the thing: between Thanksgiving and New Year's is like just one big blur for most people. It's like holiday season. There's always things going on. You're eating uncontrollably. You're doing whatever you want because it's holiday season. You'll figure it all out come January. So I think it's a perfect time because it's going to get you enough exposure, and people are also going to come into January and being like, "All right, New Year's resolution, time to lose some weight. We got to figure out my health." And there's going to be a brand new drug that's available to help with that. So I think it's perfect. I mean, if they do it
Yeah,
in January, I think a lot of it might have fell off, a lot of the hype. But you got about 6 weeks to get people hyped up.
yeah. I mean, every New Year's, just everyone's always has this weight loss sort of like resolution that they're gonna make.
Yeah.
So I think they're doing at least from a marketing standpoint, I think it's wonderful from what they're doing. You have people who are already starting to think about weight loss come Thanksgiving because they're going to be eating so much with their family. Then you have Christmas. Oh man, I just ate way too much. Well, it's weight loss time. This company is just like they're advertising for it. But I think it'd be interesting to follow Eli Lilly's stock. Come next year. I would love to see Q4 and then Q4 results of this year and Q1 results of next year because I think it'd be pretty interesting to see how much are they actually selling because of the results of this being marketed after Thanksgiving.
So we'll actually show you guys a chart about Eli stock when we get to one of our later articles, but we'll see how it's risen from early this year to now. It's pretty astounding.
Yeah.
But in terms of Zepbound, so it is a brand new drug. It's going head to head with Wegovy. I think it was like a 70-week trial. The average weight loss at the highest dose was about 52 pounds.
Yeah, it says it right here. In phase 3 clinical trials, a 15 milligram dose of terzapatide, hopefully I'm saying it correctly, the highest dose, it led to an average weight loss of 22.5% body weight. Jesus Christ, that's a lot. That's about 52 pounds. The participants in the study had obesity or were overweight with at least one weight related condition. At lower doses, patients lost weight at 10 milligrams with an average weight loss of 21% or 48 pounds. At 5
Hmm.
milligrams, which I think is on the lower end, they saw an average weight loss of 16% or 35 pounds. So, in similar trials, semaglutide, which is Ozempic or Mounjaro, I mean, sorry, not Mounjaro, Wegovy.
Oh, we go via.
Yeah, so in similar trials, semaglutide, also known as Ozempic and Wegovy, was shown to reduce body weight by around 15% or 34 pounds after 68 weeks. So, I mean, there hasn't really been a head to head study. So, you really can't compare if one drug's better to another, but you're just taking information that's extrapolated from the small population saying, all right, this population study lost more weight than the other ones. We really don't have insight. I mean, that's the problem with these studies is like, you don't have complete insight into that actual patient population. Was
Right.
this patient population more motivated? Do they use like CBT or cognitive behavioral therapy to address, their eating conditions? Don't really know, but it just sounds like, Zepbound and Wegovy do cause a further amount of weight loss than that of Ozempic or semaglutide.
Yeah, I mean these studies are great, but they're, in my opinion, pretty misleading because there's weight loss. There's so many factors. You're taking a medication, yeah, but all these studies that indicated that there's also a reduced calorie intake and regular exercise, right? So how much does that play a role? Then you have 52 pounds as like a blanket statement, but how much of that was fat? How much of that was lean body mass and muscle mass? How much of that was something else? What was the average weight of a lot of these people? I think it said it was like 231 pounds, and then it was an average weight loss of 52 pounds with this medication. But there's so many other factors that play a role rather than just injecting yourself and then all of a sudden the weight's gone. Like it's not a magic drug like that. There's other things and other factors that play a big role. Um,
Yeah, I
those things
mean,
aren't highlighted.
caloric intake is so important. I mean, if you're still eating like shit over like 4 or 5 thousand calories a day and you're not addressing that, I
Yeah.
mean, you're still going to be taking in 4 or 5 thousand calories.
And
It's that part needs to fundamentally change.
no one really understands. Well, I guess people do, but it's not really brought up. It's a simple equation, right? What's coming in versus what you're expending. So you're putting in 4,000 calories, but you're only expending 2,000 or 3,000 a day. You're at a surplus of 1,000. That is going to translate into a gain, weight gain, an increase in mass, whether it's fat, whether it's muscle, whatever it is. But it's going to be a weight increase. Like it's a very simple equation. What's in and what's going out, but no one really highlights that. And I feel like people always look for like the easiest solution.
Well, it's easy. It's
Yeah.
incredibly easy.
Yeah.
All
I
you
was
need to
like,
do is inject this drug, once a week, and you lose
yeah,
all this weight. That's great.
yeah,
But, a lot of people I talk to about GLP-1s, they always have this question: if I stop this, will I gain back the weight? And it seems
yeah.
like, no study has been done yet to sort of say, all right, well, there's a possibility or there's a likelihood you could, gain back the weight, or how much of the weight can you potentially gain back? Like, that's what I find interesting. No one has gone through with a study. I think we'll probably see abstracts, but the manufacturer's not going to pay for that study. Their
No, but
job
they're
is to
gonna.
make you stay on this drug forever.
Yeah, but they're gonna do like a comprehensive review of several studies and long term studies down the line. But I think these medications are just too new for those studies to be available yet. And the other factor is when you get off of this medication, are you going back to your old habits of just eating like shit and just doing whatever you want and not exercising? Or are you saying, all right, I'm going to remove this one tool from my weight loss journey, tool chest, but I'm still going to keep doing everything else to make sure that the weight stays down? Like that's a big factor no one considers or talks about. It's just like you're on the drug, and then if you get off, are you going to gain all the weight back? Well, what are you doing differently? If your lifestyle choices are the exact same, obviously you're going to gain all the weight back. It's like you didn't make any fundamental changes to yourself. You just put something in, now all of a sudden you're taking something out. So we'll
Yeah.
see. They're definitely going to do third party long term trials with these medications.
It'll be a while. It'll be so
Yeah,
long from
at
now.
least 10 years, probably
Yeah.
more.
I think, what's really important, a lot of people always ask, like, how does these GLP-1s work? How does Ozempic work? How does Zepbound or even Mounjaro work? And it kind of works in two different ways. The first one is it reduces glucagon, which is pretty much glucose that's stored as fat in your body. But the second part, which I think contributes to the weight loss, is actually it delays gastric emptying. So what that means is you feel full faster and longer.
Right,
So I think, that has to play a huge role of like, hey, I ate this much, but I still feel so full that I can't eat anymore.
right,
A lot of people, when they eat to the point when they feel full. That's just how it is. The stomach takes a while to secrete hormones, and those hormones get registered and picked up in your brain, and your brain tells you essentially that you're full. But if you're able to shorten that feedback loop, then essentially, yeah, someone could feel full faster and they're going to eat less. So, I mean, just spitballing theory here. I mean, if you were to reduce, your intake of semaglutide or these GLP-1s, I imagine you're going back to the original feedback loop that you have. It's not going to be shortened. It's going to go back to where it was. And essentially, if you don't control your appetite, if you don't control how you're eating and you're you know, putting out your proportions, then
right.
yeah, I mean, in theory, it sounds like you would need to be on this drug for quite a while.
Well, that's you kind of made my argument there, where it's
Yeah.
like, if you get off of this medication, all of a sudden you're more hungry more frequently. Everything's kind of coming back. But did you develop the self control and the tools needed to make sure that you don't go back into those old ways? Because you're seeing a visual change in your body and how you feel, and your overall energy output and all of it. It's like you feel better, so are you attributing that to just the medication, or are you attributing that to your lifestyle changes? And then are you going to maintain those lifestyle changes afterwards? That's the $1 million question, you know?
I
So,
think
and
a big part of it is actually I've noticed, here in America, people eat really fast. If you didn't
yeah,
know this, I was actually talking to a dietitian. They were telling me like you need to chew your food at least 20 to 30 times before you swallow.
40. It's
Is
supposed
it
to be
40
40.
now?
Yeah.
Oh my
I
God.
grew up like learning 40.
I didn't know that. Yeah. I mean,
Yeah.
this is something I found out like in the recent years. I was like, oh, that
Like
makes a lot
the
of
food should
sense.
essentially be gone in your mouth by the time you're done chewing, because it's just
Yeah.
so pulverized and it's already down the hatch. But most
Yeah.
people, they'll take a bite and they just like chew and then swallow. It's like one chew. Like I see some people eating like that. I'm like, dude, my chest hurts and like my entire gut hurts just looking at you eat, because
Yeah.
you're not even enjoying your food. You're not tasting it. You're not doing anything. You're not getting all the pleasures of eating food. You're just throwing it down the hatch uncontrollably. And another thing with eating over a longer period of time, like I think in Italy they have like their lunches are 2 to 3 hours. I forgot the exact statistic, but their lunches are longer, their dinners are longer. Generally, if you go to any European country, you're at dinner for like 2 hours, 3 hours. Versus here, you're like in and out within 30 minutes.
Yeah. It's different. I feel like in people in Europe, they kind of like, they actually feel like they're living. It's like an actual experience to eat. Here
Yeah,
in America, like we're always so rushed. We're constantly having to work. You only have 30 minutes for lunch break, and it's like you're kind of rushed to eat. So I
yeah.
think, that plays a huge role in the obesity epidemic that we're seeing here in America.
Plus, it's like, what are you going to do? You're going to run down the street to McDonald's and you're going to get a Big Mac, right? You're not going
Oh, I
to,
love Big Macs. I
yeah, you're
love
not going
Big
to sit
Macs.
there in front of your stove. It's probably the craziest thing is it probably takes you the same amount of time for you to get in your car, go to McDonald's, sit in the drive-through, order your meal, pay for it, get the meal, come back home, eat the meal. Let's say it's a 20-minute thing. That same 20-minute window, you can make a homemade meal that's probably 100 times healthier in the same window. It's just you don't want to do it. McDonald's is the easier option.
And that food is always so processed and it's so salty. I mean, if you have like a cardiovascular condition and you're increasing your salt intake, like, dude, your blood pressure is going to go up. Yeah, I mean,
That's what
American diet is not great.
they call hypertension the silent killer, right? Because no one knows it's affecting you till it's almost too late.
Yeah, it's really concerning, actually. I mean, if your blood pressure is really high, it's not treated, then it's could
No, because
potentially
like
shorten your life.
you can feel your heart rate when it rises, right? Like if my heart's beating at 170 or 180, like I'm like winded.
You're
But if my blood
gassed.
Yeah,
Yeah.
if my blood pressure is high, you don't feel it. You don't feel anything until you put that little arm cuff or wrist cuff on. And they're like, oh, it's not 120 over 70 or 80. It's like 160 over 110, which is not healthy. That's like in danger zone right there.
You know, interesting story. I do remember when I was working at my own pharmacy, I had a patient that came in and they used this blood pressure machine that was mounted to the ground out of our pharmacy. It's like this whole station.
Mm-hmm.
And I thought the machine was broken. So I had to take this guy's blood pressure again. It read 180 over like 90, like twice. And I was like, dude, you got to go to the hospital right now. Like, this is like, you're about to
Yeah.
stroke out. I don't know if this person went to the hospital because they're very dismissive of the whole idea.
Right. Well, I
But,
mean, you got to remember they've also been living like that for maybe 5 years, 10 years, where it's just normal. And the crazy thing is, when you first are like pre-hypertensive, which is pre high blood pressure, you feel fine, and then if you don't take care of it over the years, it'll just slightly get incrementally worse. But because it's such a long stretched out thing, you just think that, oh, I'm getting older, my body's not working as well, blah blah blah. You don't really attribute it to maybe it's like high blood pressure or high cholesterol or whatever it is. You don't really take into account all those things until you have a big cardiac event like a heart attack or a stroke or something. And then it's like, oh, your blood pressure's been high for the last 2 decades and you didn't treat it or do anything for it. Like, yeah, it's going to be an issue. You know what I mean?
yeah, okay. I remember in like, pharmacy school, we'd always compare it to a plumbing system. And basically, essentially, if you're increasing more salts, you're throwing more stuff into the sewage system or plumbing system. If you're increasing the pressure of the actual, fluid inside, it damages the actual piping of, plumbing systems. Likewise, in the same vein, if your blood pressure goes up, it damages your vessels, it damages your arteries. Your tissue can only handle so much pressure.
Mm-hmm.
And what ends up happening is if you leave it untreated for such a long time at such a high blood pressure, you're going to be running your cardiovascular system to the ground. But I mean, that was kind of the analogy that I was brought up with when I went through pharmacy school. Don't
Mm-hmm.
know how it was for you, but I imagine it was very similar.
Yeah, I mean, yeah, we can have a whole episode on hypertension. Yeah,
Yeah, I
because
don't know how we talk about high blood pressure
I
all of a
don't
sudden.
know. We got kind of sidetracked.
Yeah, we did.
But let's go back to this. So this is, I guess, an unofficial head-to-head of uh, Mounjaro or Zepbound versus Ozempic slash Wegovy. They were trying to see essentially which is the better medication. I searched for maybe like 20, 30 minutes to find the actual study. I couldn't find it anywhere. I think you tried to.
I think it was an abstract, so I think it was just a presentation. I don't think it was an actual like thesis report or actual research article that was published in a journal. But yeah, I believe this person present. Yeah, it's an abstract that was presented. It looks
Yeah.
like
So
the
if we go
ACG.
down in the analysis, I guess it was compared to a placebo with 15 milligrams of tirzepatide. Is that how we say it?
I have no
That's,
clue.
I know we're pharmacists and we're all, dude. Every pharmacist I know with all these new meds is just struggling saying them with all the monoclonal
Yeah.
antibodies and like the aclupamabs and dedupamabs and all those. Anyways, so current guidelines recommend that these agents are only used in BMI greater than 30, but very few patients are on a GLP-1 agonist and that needs to increase. That's what this person who wrote the abstract is saying. FDA approved 2 GLP-1s for the treatment of patients with obesity, specifically for a BMI of 30 or higher. Saxenda was the first one back in 2014, which I believe is going to be discontinued in the near future, by the way. And the other one was semaglutide, and now we have a third one, which is Zepbound. If you go down a little further, it says across the study, there we go. Across the study, at any dose, it was the most effective in reducing body weight compared to placebo. 5 milligram had a reduction of about 13%. 10 milligram was about 19%, and 15 milligram was about 20%. So it's pretty similar to what we just went over with the Lilly's official release, but it was more effective in this abstract compared to Wegovy slash Ozempic, which is semaglutide. So if we go to the next paragraph, it says that the mean change at the highest dose was about 13.61%. So 13% versus about 20% at the highest dose.
That's a seven
Um,
percent delta right there.
yeah, and then for those receiving a lower dose than 2.4 of semaglutide, mean change was about 11%. And then oral semaglutide was about 12%, which I'm surprised that it was higher than the lower doses of the injectable
Yeah, that's
because of
pretty
adherence
interesting.
issues and things like that. But yeah, so it's about, like you said, 7% delta. At the lower doses, we're looking at what, 11 versus 13 to 19. So anywhere from, 3 to 8%
So, I mean, when we
supposedly
look
better.
at, yeah, I
Yeah.
mean, when we try to compare, say, oral semaglutide to the subcutaneous injection semaglutide, it doesn't seem like there's any difference or meaning significant difference in weight loss for these two drugs or for these two different formulations.
Right. I mean, it's the same compound, right? Obviously, you have to go through the first pass metabolism versus it just being, as a weekly injection. I'm surprised it's slightly higher because anytime you have an oral medication, you're always dealing with adherence and compliance to treatment. A lot of patients that I like, almost all of my patients, not all, I'd say a good chunk of my patients don't take their meds the way they're supposed to every day, you know? So when you have a weekly injection, though, it's like you have Thursday morning at 9 a.m., you're going to have your injection, and then you're good till the next week. You don't really have to think about it, out of sight, out of mind kind of thing. So I'm surprised that the oral was slightly higher, but it seems like the Mounjaro slash Zepbound, according to this abstract, was slightly better than using Wegovy or Ozempic.
So, I got a question for you, Amr. I mean, why don't we see more people taking oral semaglutide or oral Ozempic?
Um, Injection's easier. It's once a week. you know,
That's true.
like I
That's true.
said, it's the easiest possible solution, right? That's what we look for. Well, I rather inject myself once a week than take a pill every single day, right?
But you still have a lot of people who are pretty resistant to, poking a needle inside their body. And it's a very small needle, by the way. But it's just like I imagine there's, some sliver of this patient population that says, hey, I don't want to take subcutaneous injections. The other thought I had is possibly that oral semaglutide, I think, causes much more GI or, a GI upset. But
Mm-hmm.
that was like my only thought I could think of. I do know that when oral semaglutide, also known as Saxenda, came onto the market, this was before anyone knew that it would have this huge weight loss potential. It was just first indicated for diabetes, and then as a result of all these like retro studies that they did, they realized, oh shit, this drug causes weight loss. And I think that's kind of like the introduction to this whole GLP-1 category in treating obesity overnight.
Did Saxenda come? It was Saxenda, then Ribelsis, and then Ozempic, right? That was the order.
Yeah, yeah, yeah,
Yeah.
yeah,
So
yeah. And then right,
Ribelsis is the
Belsis.
oral, yeah, semaglutide. That's the brand name version. Saxenda is the injectable, the first one. So the difference between Saxenda and Ozempic, Saxenda is injected every day.
Oh, okay. I
So
got
a
it wrong
lot of
then.
people, yeah, a lot of people kind of shied away from the first wave of these GLP-1s because it was a daily injection. And then they saw results with semaglutide in the oral form, and so they just figured out how to make the injectable form. And that's another reason why I believe Saxenda is going to come off the market pretty soon. I've had patients on Saxenda. So I had a patient that was on Saxenda on Wegovy. Then they had coverage issues, so they switched to Saxenda, and they were just miserable because I hated injecting every single day.
Oh wow, I didn't
But as
realize it
soon
was a
as
daily injection.
yeah,
Wow.
so the use case is so much easier for at least the pharmaceutical version of Wegovy and Ozempic because everything comes in the box. You don't have to get pen needles separately, and you don't have to screw something on and inject yourself every day, rotate sites. All of that is kind of mitigated because by the time you're at 1 week from now, the injection site's healed, so you can just go slightly to the left or right. So
What
it's
are some
just
of
the
the yeah?
convenience.
What are some of the inconveniences of taking this? I mean, do you have to refrigerate this injection every day?
Oh yeah, so they're all cold chain medications, so they're all refrigerated. Um, But outside of that, it's just if you're uncomfortable injecting yourself, then obviously that's a big barrier that you have to break through. But besides that, I mean, everyone that I have on it loves it, and
Interesting.
it's once you inject yourself, out of sight, out of mind for another 7 days. Just put a little reminder on your phone, on your calendar, and every 7 days, Thursday, 9 a.m., poke yourself and you're good.
Yeah.
So, but there's
Interesting.
definitely going to be more medications in the same class coming out. I
That's a
know.
billion dollar industry. Of course, you're going to see more manufacturers trying to get a
Yeah.
piece of the pie, for sure.
So
You know,
there,
there's something interesting I actually wanted to point out, and no one really talks about this. Is that, I mean, they do talk about it, but there's a black box warning on all these GLP-1s. And the black box warning is essentially like there is a potential that this drug can cause thyroid cancer. But I've actually looked into this, and I think they're extrapolating this data actually from rats. In rats, they actually showed a higher incidence of thyroid cancer or some sort of malignant growth. But I don't know if that do rat models translate over to a human being? Doesn't seem
no,
like it would.
it's apples to oranges, man.
Yeah. But it's just very interesting that, I've been seeing this black box warning, and there's a black box warning on it's like every drug. A lot of people don't know this, but antidepressants, they have a black box warning on it. It can cause suicidal
Suicide.
ideation. Yeah. And it's actually pretty dangerous. But a lot of people just, understand, all right, well, here's this possibility of, this dangerous side effects approaching and, to sort of just monitor it. But yeah, black box warnings have been around for such a long time.
Yeah, and they never get brought up. They're always like brought up once, and then people just forget about them. Let's actually go to the who's driving the craze and the Wall Street hikes first,
Okay.
before we go into this muscle. So this was a solid article about just the interest of what demographics are interested in these GLP-1, specifically Ozempic, Wegovy. I'm assuming these numbers will change now that there's another new med that's out. But I just wanted to highlight the 28% of U.S. adults said they are interested in GLP-1 drugs, like Ozempic, Mounjaro, Wegovy, and now Zepbound. A lot of people have heard about these, and that's why they're interested. If you scroll down, there's actually a solid chart.
Is there? Let's take a look at
Yeah,
it. Oh,
right
wow.
here. Yeah, yeah. So let's see. Let me open this up. So all adults, about 12% were very interested, 16% somewhat, and then it goes 10, 14, and 48. So about 48% of adults are not interested at all. What's interesting is when you break these down into different categories, the people that have heard a lot about the GLP-1s, they're pretty interested, probably because they've heard only positive things. Somewhat interested is about 21%. So you're looking at about 45% of people that have heard about this medication or this class of medications that are actually interested in taking it. As you go further down, if they have weight related issues, that number jumps up to about 51%. But this next one, which is pretty substantial, is the household income one. So these medications, they're not cheap on the pharmaceutical end. A box of Wegovy costs about 1,300 something. I think Zepbound is going to be right around 1,000. Ozempic's right around 1,000 too. I don't know
Yeah,
off the
I
top of
think I
my
think
head.
what I saw, Zepbound is priced at 1,060, and then
Mhm.
Wegovy's priced at like 1,300. So it's like almost like a $300 delta right there, 240 to be exact.
Okay. So, yeah, I mean, with that cost, and here's another thing. So, with coverage concerns and things like that, a lot of these medications aren't on most plans, they're not covered. So, affordability plays a huge role, in having access to these medications. So, this household income of 100,000 plus kind of brings it to light that, people are paying out of pocket. They're going to be more likely to be able to afford it and even do it. So I think it's a little skewed also because it's kind of putting a threshold limit. But then the last one, which was pretty funny with millennials, considering that we're millennials, about 17% are very interested and 22% are somewhat interested. So the bar actually is higher for people that are not interested. I wanted to ask you what your opinion on that is. What do you think is the cause and reason?
Here's the problem. Okay, I feel like everyone talks to me about this, and I don't know if it's because I'm a pharmacist, but like this is all I hear about. So I feel like there's some sort of inherent bias of like I do feel like a lot of people are interested in this.
Right.
I mean, if you told me only like 17% is very interested and 22% is somewhat interested, I'd probably tell you like I feel like that number is skewed much higher than what it's reported. So I don't know. I feel like this number is definitely much higher. The
Yeah.
sample size that they probably had is probably just located in one regional area. I don't think they surveyed the entire America, of course, but I do think that percentage is much higher.
Yeah, the survey was taken October 16th to 19th among a representative sample of about 2,200 people.
That's not a very big sample size.
Yeah, so it's a small sample size, but I mean, the numbers will vary, but it's not going to go from like 22% or 17% to like 90.
Yeah,
I just
that's
think,
true.
the younger, maybe people in the younger generations, they're just doing more lifestyle changes first than, just trying to find an injectable product that they can just utilize.
Well, here's the thing: a lot of millennials are work from home right now. Majority of them, right?
True.
So I imagine a lot of them are like, "Oh, let's go outdoors. Let me go do something else." There's a little bit more freedom with your time, and maybe they more in tune with weight loss or their fitness journey.
Right.
But I would actually be surprised that if a millennial didn't hear about this. Like that's kind of like how is 10% or don't know about these Ozempics or these GLP-1s? Because I mean, every millennial has almost Instagram or some sort of social media app, and I'm sure they've seen this come up on social media apps. This isn't
Yeah.
something that's like, oh, I'm blindsided by healthcare news. It's it's a very interesting drug, and a lot of people do know about it. It's almost like Viagra, I think, on the same level. Everyone knows about Viagra.
I think 10%'s accurate, you know,
Really?
of a certain level of people that just aren't on social media or don't watch TV or, you know, they're just kind of disconnected with the electronic world. It could be higher, but yeah,
Yeah.
it's funny because the other categories are even lower percentages. But yeah, that was it. So it's just showing kind of the interest groups for these medications. If you toggle over to the next one, the Wall Street hikes forecast for
Oh, hold on. Sorry.
anti-obesity drug sales.
Wall Street hikes. Wow.
100 billion.
100 billion. That's
Yeah.
crazy. They
So
think this industry is that big for weight loss?
you brought up, it's going to be $1 billion industry. Well, times that by 100, it's going to be $100 billion industry
I mean,
by
these analysts
20.
always just take a shot in the dark. I mean, that's crazy. 100 billion.
So the original estimation, if you scroll down, was about yeah, right there, second paragraph. It was about 55 billion. That number has jumped up to 71 billion. But a lot of these firms and predictors are saying that it's going to be 150 to 200 billion for these drugs by 2035. So that's a huge market.
So, which company should I be investing in? Novo or Eli or both?
Both, right? Eli's going to take off in the short term with a new drug. People are going to be like, "Oh, Wegovy's not available. Let's switch everyone to Zepbound or Mounjaro." But just if these two companies are the only ones that have market share for X amount of years, stock price is going to go through the roof.
Yeah, I would love to dive be deeper into how some of these firms are making these cases. A
Yeah,
big part of it is like who's covering this. If you're expecting people to pay out of pocket $1,000, $2,000 a month, like that's a hard sell.
right.
I see like 503A compounding pharmacies selling this for like $200 to $300 for a month supply.
Hmm.
It's by far much more affordable than buying the commercial version of these GLP-1s. So I think maybe I'm just like putting on my thinking cap here, but if you're not going to have Medicare pay for this, if employers aren't going to pay for this because they realize it's another, line item that they have to pay for benefits, like who's going to pay for this? The only health plan I'm aware of that actually covers weight loss right now is California Medicaid. That's it.
There's commercial plans that do.
Okay, maybe some
Yeah,
commercial plans, but
there are
again,
some commercial plans.
commercial plans are usually put on by employers.
Right.
But what about people who are 65 and older, or what about people who are in a different state and they're on Medicaid?
Well, weight loss drugs are by law not covered under the Medicare program.
Yeah,
So that's a big chunk of the population. Medicaid covers all of them straight off the bat. No issues needed. Paid
that's what I find
claiming.
weird. Yeah,
Yeah.
that's what I find really weird because like, some employer groups they'll cover weight loss drugs, but not all of them. But then you
Right.
have our state Medicaid, which covers it 100%, which I find really bizarre. It's like the working class like can't take care of weight loss, but then the Medicaid population, like they get it covered 100%. That's just kind of weird to me.
Yeah, I mean, we could go into a whole separate
Yeah.
episode of the Medicaid program. It'll be like
Yeah.
a mini series of like
If we
50
talked about
episodes.
Medicaid, I mean, especially in just California, like my head would blow up. There's
Yeah.
just so many problems with it. Oh
Um,
man.
but if you scroll down, we can see Eli's price, Eli's stock increase.
$600.
Look at that. So from March to November, we went from about $300 to what, right under 600. So a little
Jesus Christ.
2x
It's
stock
tapped
share.
over 600. Yeah, it's tapped over. That's crazy. This
Yep.
company basically did like almost like a 2x.
Yeah. Within a year.
What was in the 2000s? $57. My god, dude.
So that's Eli.
In 10 years they did pretty much like a 20x, right? No,
Yeah,
30 times 20.
let's see.
I think it's 20. That's crazy.
5 years. Yeah, July 5 years ago was about $100.
I'm waiting for Bitcoin to have a god candle.
Yeah.
Looking at this chart, I'm like, man,
If only it was orange. Why is it
it
blue?
was orange. I know. Bitcoin's way too volatile. But
Yeah.
with any new technology, you're going to see volatility.
Right.
But not in
So
pharma.
pharma's well, now they're capping it, right? Capping drug price increases, which is a good thing. But we'll
It's,
see.
there's this problem. Like when I have a huge problem explaining the Inflation Reduction Act because everyone's like, oh yeah, that's less money for Medicare that they have to pay out. But they still don't realize, like, if that means pharmaceutical companies are going to be paid less from Medicare, they're going to restructure how their rebates go to every Medicaid program. They're going to restructure how it goes to every employer.
Mhm.
What does that mean? Essentially, what that means is the working class has a higher deductible, higher copay, a higher share of cost. And also, by the way, that drug that they're on, it might not even be covered on the formulary anymore because they have to reduce costs somewhere. So I think it's just like ticking time bomb that no one realizes. It's going to take, another 5 to 10 years for the Inflation Reduction Act to fully realize all its benefits for Medicare. But the people who are on Medicare, I mean, that's everyone else.
Right.
I think it's a little bit scary.
You think it's
But
going to
again,
be? They can't disproportionately charge more for commercial versus Medicare either. Like they
no,
just
but they can affect the rebate structure.
right.
Certainly.
Well, like there's certain products that have a separate NDC for Medicare, Medicaid versus regular. So it's like you have a Medicaid, Medicare box, which is $7, and then you have the retail box, which you have to use for commercial plans and everybody else, and that's $34. It's the same exact thing. It's just
But here's the problem. When you have that sort of incentivized system, the pharmacy is going to be like, I don't want to buy this and put it on my shelf if I can only bill one customer for this insurance plan and I can only carry this product for, that insurance plan. It
right.
becomes like, at this point, this is like ridiculous. Like, what if there's a drug shortage for this one payer, Medicaid, but then, I have the same drug on the market in my shelf, but
Yeah,
I can't bill it to your insurance. Like, it becomes a point of like, these drug rates are so ridiculous. Like, it takes
yeah.
away from the patient care.
Well, yeah. It's not patient care is not the forefront of the problem solving.
I mean, I wish they did away with drug rebates, but again, you're talking about
Not gonna happen,
a
man.
practice that has, been around for
Fueled the pharma
centuries.
industry. The rebate structure is what fuels growth of the pharma industry. One of the big factors.
Yeah. No one talks about it, which is really weird to me.
Yeah. Uh, let's jump into this final, caveat of this drug class. I brought this up before, but the one of the big concerns, in my opinion at least, is how much of this weight loss is actual fat mass loss versus skeletal muscle mass loss, or reduced bone density or whatever else it is. How much of those factors are playing into the overall pounds of weight lost, or the overall decrease in BMI, or overall weight? Um, if you toggle over to that Forbes article, there's going to be a new trial, I believe, in Q1 or Q2 of next year, that's going to see if Mounjaro specifically, alongside an experimental treatment, can show if there's actually a maintenance in muscle mass or if muscle mass is also being reduced. Eli Lilly, which makes Mounjaro, has a developmental arm called Chorus, and they're doing a joint trial sometime next year. But the main takeaway from this is that they're going to actually test to see if there's weight loss in just fat loss, which is essentially what's important, or if it's overall weight loss, which you're losing muscle mass and everything along with it. If there is a substantial, percentage of muscle mass lost in addition to fat loss, then you're just reducing your overall weight. You're not really getting healthier, in my opinion.
So
It's still
there's a key fact here on this article, and it says that BioAge Labs is going to be co-administering its muscle loss drug, azelaprag, with
right.
Mounjaro. Like, do you not see the next wave of drugs that will be coming out? It's going
Yeah,
to be a combination.
yeah, of course. That's what I'm saying.
Oh
Yeah.
man.
This is just the scaffolding. They're like, okay, well now we realize that you're losing muscle mass as well as fat, so we have this new agent, this new compound that mitigates the muscle loss. So you'll just lose fat.
A
Yeah,
lot of those like muscle loss drugs, like I want to say like Anavar is like one of them. I mean,
yeah,
that usually is just given to patients who have cancer.
right.
So, I mean, do you sort of foresee like, hey, we're going to try to mix a GLP-1 with some sort of like muscle loss drug and see if we can have a better outcome for the patient and market that not at 2,000, but like 10,000?
High
Yeah.
likelihood, right?
Yeah. It's crazy like where this industry goes, like once they can run with something.
So the main reason I bring this up, if you scroll all the way down to where it's a surprising fact, um, a clinical trial of semaglutide, the active ingredient in the weight loss drugs Ozempic and Wegovy, indicated it could result in nearly as much loss of lean muscle as pounds of fat. Participants lost about 15 pounds of lean muscle mass on average compared with 23 pounds of fat during that 68-week trial, the same trial that we attributed, in the earlier head-to-head abstract. So if you're losing, 1/3 to 2/3 ratio of muscle mass to fat, I mean, yeah, you're still losing a lot of fat, but you're burning a good chunk of your muscle mass off, which is important for longevity, for health, all these factors to live a long life. So is it good? I don't know yet. These long-term studies will tell. But yeah, if there's another drug that comes out in the next 5 or 10 years that combines two different things to mitigate the muscle loss, then it's going to be maybe a $500 billion industry right there.
Yeah, that's pretty big. So, I mean, I don't know the numbers here, but if someone were to go on a weight loss journey without the use of these GLP-1 drugs, what's the ratio of fat loss and muscle mass? Because I know you do lose muscle mass, when you do lose weight,
Right.
but I just wonder what that percentage is. I mean, is it much higher, lower than what we're seeing here?
I mean, dude, there's like a unlimited number of factors that play into that, right? Because it's like, are you just calorie restricting? Are you calorie restricting and are you exercising? Now, what does your exercise consist of? Is it just running? Is it just cardio? Is it strength training? Is it functional training? What is it? If you're doing strength training and functional training with cardio, with the reduced calorie intake, and you're seeing results and you're not taking any of these medications, well, you're going to build some muscle and you're also going to lose some fat. And then if you severely restrict your calories, you're going to lose a little bit of muscle mass, but you're still strength training and conditioning to make sure that you retain most of that muscle mass while losing fat. But if you're not doing any of those things and you're just injecting yourself, you're going to lose both. That's clearly what these studies are indicating, that it's an overall loss in weight, not just a loss in fat, which is a very big distinction that people need to make.
Yeah, no, that's huge. I mean, if you're losing, muscle mass and it's an alarming amount compared to fat, then yeah, it could have unintended consequences. And muscle is broken down to like what, two or three categories. There's skeletal muscle, cardiac muscle. I wonder how much of that is actually cardiac muscle that you're losing. I mean, that again affects your heart.
Right. So I'm interested to see. We'll definitely cover this trial once it's released next year.
Yeah.
But I want to see what the results really are. Um, I think that's about it.
That's it, at least. We're up on time. Almost 1 hour. Wow.
So we'll definitely keep y'all updated on this class of drugs. I know there's a lot of interest, so we want to cover it as much as possible. Obviously, when Zepbound hits the market, we'll do another mini-sode or something to see how the coverage and things are. As I get more prescriptions and things like that too for these things, I'll try to see what the coverage is. Give you guys an inside scoop of whether it's actually covered or not.
That's so funny.
Yeah.
All right. Well, until next
Alrighty.
time, thanks
Take
guys
care,
for
guys.
listening. I'll see you.
See you later.